Good morning, everyone. Thank you so much for joining us today. I'm Emily Marchese, the Executive Director of Reach Out and Read of Greater New York, and I'm so excited to get to spend the day with all of you. Thank you so much for taking the time to learn together, to share together. It's such a gift to reach out and read, and to all the children and families that we work with to get to join forces today. Please use the chat to introduce yourselves and share where you're from. We've got friends from all over New York City and all over the country joining to share and to learn together. For any new friends who are new to Reach Out and Read, we have been around for over 35 years as an organization serving children and families by training pediatricians and medical professionals on early literacy, so that at every well child visit between 6 months and 5 years old, about 10 appointments on average, families are receiving excellent anticipatory guidance on reading to their child every night. And they're also receiving from Reach Out and Read a new developmentally appropriate and linguistically appropriate book so they can begin building their home library. And we are able to serve here in New York over 250,000 children every year in partnership with all of you who are joining us today. And so I really encourage you to use today to serve your best purposes. Use that chat to ask questions. There's no such thing as a silly question. I guarantee you, if you're thinking of a question or if something isn't clear to you, there is somebody else on the call today who has that exact same question. So please feel free to ask it. Also, please feel free to comment and share. If there's something that the panelists are sharing that really resonates with you and your practice, we'd love to hear about it. And similarly, if your experience is a little bit different, we would love to hear about that as well. Our best and strongest decisions that we've made as an organization over the past few years have been through speaking with all of you and learning from what's working best in your clinics, whether it's been prioritizing bilingual books for our children and families, revamping our site visits, even thinking about how we're hiring and staffing positions. That's all come as a result of the high quality feedback that we get to learn from all of you. So I do encourage you to share, to use that Q&A all throughout today. And also, please feel free to email us and share feedback on how we can make this conference better and stronger in the future. We're so excited to get to spend today with you. And speaking of people that we're very excited to work together with, very excited today that Reach Out and Read National CEO is joining us this morning. Dr. Fraga has dedicated her career to promoting the well-being of children and families, holding leadership positions in nonprofit, corporate, and academic institutions. As CEO of Childcare Aware of America, she doubled federal funding, increased philanthropic support by 35%, and established the organization as a national thought leader on childcare policy. And at 0 to 3, she promoted the importance of early childhood development and learning through programs like Early Head Start, spearheaded initiatives to support military families in the wake of 9/11, and reimagined child welfare through the nationally recognized Safe Babies court teams. She also served as Vice President of Special Populations and Nonprofit Relationships at Care.com, developing strategies for supporting military families, veterans, and individuals with special needs. Most recently, she founded Fiercely Forward LLC, where she coached nonprofit executives, particularly women and leaders of color, through periods of transition and transformation. How lucky we are to have Lynette at the helm. Lynette, welcome.
Hi, Emily. I'm so excited to be here today and also thrilled to see folks in the chat sharing where they're from. It's really wonderful to see this community come together. And thank you so much for inviting me to be here this morning. I really appreciate it. I am so grateful to join all of you for Reach Out and Read Greater New York's annual conference. And I'd like to start by thanking the Greater New York team for bringing together this community of clinicians and advocates and educators and researchers and partners who care so deeply about children and families. I want to acknowledge, firstly, the work of this affiliate done in partnership with so many of you. Again, I'm so appreciative of all these names popping up on the chat. I really am honored to be at the helm of Reach Out and Read and in this community with all these fabulous people. Um, the work of Greater New York has built something extraordinary, not only in scale, but in the way it reflects and responds to the communities it serves. New York City is one of the most diverse places in the world. Families here speak hundreds of languages. They come from different cultures and traditions and immigration experiences and family structures. And Reach Out and Read Greater New York has embraced that reality, not as a challenge to work around, but as a strength to build from. You can see it in the books that they choose and the partnerships they build with all of you, and the way they think about clinics, not just as places families go for care, importantly, but as welcoming spaces where families can feel seen and respected, connected and supported. And that is exactly why I know this year's theme, Beyond the Prescription, Creating Welcoming Clinics Through Literacy and Connection, which, by the way, love that, matters so much. Reach Out and Read has never only been about giving a child a book. I want to be clear, the book matters deeply, but what has always made this model powerful is the relationship around the book. It's the clinician sitting down with the parent and showing them how to hold a book with their baby, and the trusted guidance those clinicians offer, demonstrating to a caregiver, you matter. Your relationship with your child matters. The time you spend talking and reading and laughing and connecting is shaping your child's future. That's powerful. And in a moment like this, when so many families are navigating uncertainty and stress and isolation and barriers to support, those connections matter even more. The moments can feel small when they happen in just an instant, but over time they shape relationships and confidence and language development and the way families connect with their children. We all know that families are carrying a lot right now. Parents are stretched thin, communities are navigating uncertainty, pressure from many directions. And in that environment, creating spaces where families feel comfortable and seen and supported matters enormously. You all know this. That's why I appreciate the direction of today's conversation. You're going to talk about things like anticipatory guidance and clinician modeling, the heart of what makes Reach Out and Read effective. You'll talk about supporting immigrant families with trusted resources, and you'll talk about clinics as community and community hubs that connect families not only to books, but to broader systems of care and support. Those conversations reflect where this work is headed nationally. Across Reach Out and Read, we're thinking more deeply about how to strengthen early relational health, ensuring families feel welcomed in pediatric spaces, and support clinicians who are carrying so much right now. And tied to it all, how we continue building systems that meet families with dignity, cultural responsiveness, and practical support. That includes making sure children can see themselves in the books they receive. Every child deserves to open a book and recognize their family and their community, their language, and their experience. And caregivers deserve to feel that the guidance and support they receive honors who they are. That commitment is something Reach Out and Read Greater New York has modeled for the entire network. The affiliate now serves more than 185,000 children across New York City, Long Island, and the greater Hudson Valley, primarily in low-income communities. That reach represents countless opportunities for connection and moments where a clinician can help a family build routines, confidence, language, joy, and relationships that support healthy development from the very beginning. Nationally, that's exactly what we're working toward, transforming pediatric care into a place where nurturing relationships and early literacy are recognized as essential parts of child health. Not extra, not optional, foundational. I'd like to recognize everyone who is doing this work on the ground every day, the clinicians, nurses, medical assistants, social workers, literacy specialists, clinic staff, researchers, community partners. This work is not always easy. In fact, it's oftentimes super tough. You are supporting families through incredibly complex realities, and yet every day you continue showing up with compassion, consistency, and care. That matters more than you know. The relationships you build with families create trust during some of the earliest and most important years of a child's life. And those small moments, giving a new book, modeling shared reading, encouraging a parent, helping a family feel welcomed, add up to something much bigger. They help children thrive. Thank you again for Reach Out and Read, to Reach Out and Read Greater New York, for your leadership, your vision, and your deep commitment to families across this region. And in fact, giving all of the folks that are joining you across the country. And thank you to everyone here today for being part of this work and this community. I certainly am thrilled and excited about being here. I'm excited for the conversations ahead, and I hope today leaves us energized, connected, and reminded of what's possible when we center relationships, literacy, and belonging in pediatric care. And now I am going to pass this over to Dr. Mogilner, Reach Out and Read Greater New York's medical director.
Good morning, everyone, and welcome. Thank you all so much for joining us today for Reach Out and Read of Greater New York's annual conference. We are so excited to spend the morning learning together and reflecting on the important role that healthcare providers, clinics, and community partners play in supporting children and families through early literacy and relational health. And I just want to say how exciting it is for me to see everyone posting in the chat from all around New York, but really all over the country, and yes, even international. A shout out to Carmen Ramos from the Philippines. I think you get the prize, as far as I can tell, for coming from the farthest. So it's really amazing to see the names of old friends and also see new people joining. And we are so excited that each one of you is joining us today. Before we begin, I'd like to quickly review today's learning objectives. Today, we'll be exploring the evidence behind anticipatory guidance and clinician modeling as tools to strengthen early literacy, language development, and early relational health during well-child visits. We'll also discuss ways to support immigrant families through trusted, culturally informed resources and approaches that help build trust and navigate sensitive conversations in pediatric settings. And finally, we'll examine how pediatric clinics can serve as community hubs by integrating Reach Out and Read into family-centered care, strengthening referral pathways, and connecting families to literacy and community-based supports. So one little order of business, as a reminder for those of you who are interested, this conference is approved for 3 CME credits. So if you're interested in receiving your credits, please complete the post-conference survey or form after the session in order for you to receive your certificate. And you will receive that by email. So as everyone knows, Reach Out and Read, and as you've heard, is much more than a book giveaway program. It's a multi-component intervention that includes providing developmentally and culturally appropriate books, creating literacy-rich clinic environments, and supporting clinicians as we model shared reading and deliver anticipatory guidance to parents during well-child visits. Together, all these pieces help strengthen parent-child relationships and support healthy development. It's now my great pleasure to introduce our keynote speaker this morning, Dr. Manuel "Manny" Jimenez. Dr. Jimenez is an associate professor of pediatrics and family medicine and community health and research director at the Boggs Center on Disability and Human Development at Rutgers Robert Wood Johnson Medical School. He's an attending developmental and behavioral pediatrician at Children's Specialized Hospital. He's also co-lead for the New Jersey Alliance on Clinical and Translational Science Community Engagement Corps. Dr. Jimenez's work focuses on promoting optimal relational and developmental health for children and families and making the health system more responsive to their needs. Dr. Jimenez uses quantitative, qualitative, and community-based participatory research methods to ask policy-relevant questions, as well as propose and test sustainable solutions to real-world problems impacting children and their families. We are incredibly grateful to have Dr. Jimenez here with us today. Please join me in welcoming Dr. Manny Jimenez.
Thank you so much, Dr. Mogilner. I'm really grateful to have the opportunity to be here today. If we could advance the slide. And the next 2 slides, actually. Okay. So today we're going to focus on really reviewing the Reach Out and Read model, as Dr. Mogilner mentioned, but then also reviewing some theoretical concepts and empirical evidence that really serve as a rationale for why it's so important to implement Reach Out and Read in a high quality way during our opportunities with families at well visits. And then we'll spend some time looking at Reach Out and Read components that really drive impact with an emphasis on clinician modeling. Next slide. So I think it's always helpful to start with a vignette. And this is an amalgamation of different cases that I had seen over the years that really motivated me to get involved in this work. And so Nelson is an 8-year-old boy presenting for an ADHD evaluation. His parents first became concerned with his learning and behavior last year when his teacher suggested he may need to be held back in 2nd grade. Now in 3rd grade, his academic performance has further declined. Next slide. Nelson struggles with reading. When asked to read out loud in class, his pace is slow. He makes several errors. He's unable to answer questions about the text that he just read. Lately, when called on in class, Nelson tries to make the other students laugh. When pressed, he refuses to participate. He's distracted during class assignments and initiates conversations with his classmates during instruction. Next slide. He lives with his mother and father and 2 younger sisters. His family emigrated to the US from Honduras before Nelson was born. Neither parent completes secondary school. His father works in construction. His mother works at a warehouse. His family mostly speaks Spanish at home, although he was exposed to English largely through media since his first year of life. He began shifting towards predominantly speaking English when he began preschool at age 4, which is a common pattern that we see. Despite the current academic concerns, Nelson has not received additional academic support, nor has the school initiated a child study team evaluation. Privately, a teacher's aide approached Nelson's mother. She suggested that Nelson appears to be showing signs of ADHD, and in her experience, medication can really help children like him. And so, again, that was a representation of many different cases that I saw, but it really it raised a question that was much deeper than whether or not kids meet the diagnostic criteria for ADHD or whether we should be prescribing medication. It really raised the issue of what was going on contextually. And so, being part of a land-grant university, it's our mission to be focused on our local community and really thinking about how we can help address the questions that are facing our community. And so, I shared this statistic from New Brunswick, and according to our most recent standardized testing, 8 out of 10 3rd graders don't meet grade reading level standards. Now, this is in New Brunswick, but this is also the case in many urban areas across the United States and many areas across the United States, period. Next slide. And these differences begin early. And so this slide summarizes seminal work by Hart and Risley, which I'm sure most of you have been exposed to and have seen in the past. And so what Hart and Risley did was they went into the homes of children and they stratified in groups based on income. And what they found was that children from higher income backgrounds were exposed to thousands of more words compared to children, and when you extract to children from lower income backgrounds. And when you extrapolate out over the course of the child's first 5 years of life, that becomes a difference of tens of millions of words of exposure, which has become popularized as the 30 million word gap. And now, so, there's certainly limitations to the work that have been cited by many. But that said, these results have been replicated. And despite the limitations, it really does force us to reckon with a few questions, particularly in light of what we know about child development. And so next slide, please. So first, kind of returning to principles of language development, we know that children learn what they hear the most, and that children will learn words for things and events that interest them. Interactive and responsive rather than passive experiences really promote language learning. Children learn words best from meaningful contexts, and diversity of word language structures matter. And then, the process of vocabulary and grammar development are reciprocal. Now, importantly, like particularly given the vignette that I presented, and I think much of what will be discussed later today as well, these principles hold whether you're learning one language or more than one. Next slide. And so additionally, what we know about school readiness is that it's probably one of the most powerful and holistic measures of well-being that we have for children, right? So its predictive value extends to third grade and well beyond. It predicts key health indicators and then indicators of wellness in general. So things like college attendance, earnings, retirement savings, which really are going to drive well-being for a person. Next slide. And as pediatric professionals, we truly have a unique opportunity to do something about this at the time that matters. So next slide. First, unique to our sector in healthcare, we have near universal access to children in the first 5 years of life. So access to public health insurance through Medicaid and the Children's Health Insurance Program, have expanded access to primary care. And as a result, the reach of the healthcare sector really exceeds other sectors. So even in the context of universal preschool, children typically won't start until age 3, whereas they've already seen their pediatrician a number of times before that, between ages 0 to 3. Next slide. And so, as we know, Bright Futures recommends upwards of a dozen visits in the first 5 years of a child's life. Next slide. And although the attendance at these visits recommends falls short of sort of recommended levels, and there are real differences based on racial and ethnic backgrounds and socioeconomic backgrounds in terms of attendance, and these inequities persist. But despite that, across groups, we actually see pretty high attendance. And so it exceeds 50% among all groups. And you can see how the breakdown amongst subgroups as well. And so we have near universal access to kids, frequent contact. Next slide. And then additionally, and this is important that we can't take it for granted, but we do have an opportunity to both build and build on parent-clinician relationships. And so, qualitative work by my team and my colleague, Jamie Peterson in Oregon, has shown that families seek advice from pediatric professionals regarding child development and parenting. And again, we can't take it for granted, but we do have an opportunity to build on trusted relationships that we have an opportunity to develop in primary care. Next slide. So before continuing on with this discussion, I just want to rewind the vignette and kind of think about what that, so, we sort of looked at the presentation at around third grade. Now let's go back and kind of think about what this may have looked like when Nelson was 1. And so his mother brought him into his preventive care visit right around his first birthday. The visit went fast. The pediatrician ran through a list of questions and told Nelson's mother that he was doing great. At the end of the visit, the pediatrician handed Nelson's mother a children's book written in English, and his mother was grateful for this gift. When they got home, Nelson's mother tried reading with him, but she doesn't read English, and Nelson took the book, put it in his mouth, threw it on the floor. He squirmed out of his mother's lap. She concluded that she must be doing something wrong, or perhaps he was just too young. And so again, this is for any of us who've had a 1-year-old sitting on our lap and trying to read with them, we recognize that this is very common and something that in fact, is sort of illustrative of the norm. And yet, we can't take that for granted that we all kind of share that frame in terms of experience. So next slide. And so, coming back to the unique opportunity that we have in primary care and in promoting optimal relational and developmental health, when we think about what are the things that we can recommend families to do together that might support optimal developmental health, shared reading is an important one, right? So it exposes children to more complex vocabulary and language structure, enhances child receptive expressive language development. It promotes social emotional development. And it's even associated with shaping parenting behavior. So work by colleagues at NYU, Dr. Canfield and colleagues demonstrated how it can foster positive parent-child interactions, and some of our own work demonstrate associations with less harsh parenting. And so this in no way diminishes other activities that families can do with their kids around talking, singing, other opportunities, storytelling to promote language-rich environments. But it does support shared reading as one that can add and enrich those experiences as well. So not replace, but build on. Next slide. And so, of course, here, preaching a story that we all know, but two visionary pediatricians and their colleagues saw this opportunity in Boston in 1989 and started the Reach Out Read program, which truly met such a need that I think, just intuitively we all feel when we encounter families and an opportunity. And so, next slide. Um, Scores of articles now support the power of the Reach Out Read model and increasing the frequency of shared reading, enhancing language development. There's even emerging evidence really pointing to enhanced parent-clinician relationships as a result of implementing Reach Out and Read. Next slide. And again, so much so, when you look back over the years from the beginning of the Bright Futures guidelines, shared reading was mentioned as something that should be encouraged as part of anticipatory guidance. But the Reach Out and Read model and its implementation really built that into, and the evidence surrounding it truly built it into a standard of care for pediatrics. As was first indicated in the initial policy statement in 2014 and then revisited just a few years ago. Next slide. And so that said, there's always a journey and really sort of thinking about what are ways that we can continue to improve on the work that we're doing. And so one of the areas that our team has really focused on is really thinking about how we amplify the impact of Reach Out Read, particularly for Latino families. Latino families are more likely to have heard the advice to read with their kids, but are less likely to do so. And then importantly, and again, this doesn't reflect on the power of the Reach Out and Read model, really the pervasiveness and depth of the disparities that kids encounter. But even after being exposed to Reach Out and Read, language scores fall below the overall population and kids remain at risk. And so it really offers an opportunity to think about how do we sort of build on this impact? How do we really leverage the opportunity that we have with Reach Out and Read? And so that's over the past decade or so work that our team has been focused on. Next slide. So I'll start by sharing what we heard from families in the beginning of this work and throughout the work, really kind of focusing on the family voice and elevating the family voice. And so we spent a lot of time working with families, interacting with them, having conversations with them to understand their perspectives on shared reading. And so this is what we heard from some of the families in our local community. So first, a feeling of really feeling that they ought to read, but don't. And so I'll share this quote. Because if one would dedicate at least a half hour to reading every day to kids, it'd be great for them because they would not be battling as much in school. They would be fine, but one does not do it. We also found that that the frame that we have of shared reading wasn't necessarily what the families were kind of experiencing or thinking about when we were talking with them. And so here's a description of shared reading from one of the families that we interacted with. That really described it more as reading as structured or sort of drills. So I do have time, although there are times that I do not want to stick to a book and read to him. But like I tell you, when I have the will, then I sit with him and I make him read and make him paint. I have a board on the wall as well, or sometimes I put the colors, I put the letters, and I start reading. Not reading, but saying the letters or saying the colors. And like that, very little reading because I think I'll fall asleep reading. And so this was actually a parent of a 1-year-old. And so, I think there's really an opportunity when we think about how we implement Reach Out and Read, how we can model reading, how we can sort of prepare or engage with families to sort of create a frame of what reading can look like in this age group. Next slide. We also found that parents interpreted children's developmental milestones and their behavior as a lack of interest in reading or perhaps lack of readiness for reading, despite the pediatrician's advice to read with their kids. And so one parent shared, I tried to read to her, my daughter still doesn't do advanced things. I'll play with her and all that, but that's it. Since she's going to start talking soon, she'll be able to tell me what she wants to do. Another family interpreted the child's behavior as indicating that they didn't want to read, as opposed to attributing it to kind of a developmental stage. So I thought it would be easier. I thought I'd sit down and he'd sit down with me and would look at the book and pay a lot of attention. But that's not how it is because he's still a baby. Once he starts showing a little bit of interest, I think that little by little, he'll start liking it more. Next slide, please. Parents also were concerned that their own language skills or literacy skills limited their ability to help their children. And so one parent shared, sometimes with some books, I feel that I'm not useful because my problem is that I can't read English. Another parent shared, well, I read him the little bit that I know because I don't know how to read well. Next slide. Now, we also heard about the power of the Reach On Read model. And so how receiving advice from a pediatrician, a trusted messenger, and the children's book really facilitated engagement with Reach On Read. And so one parent shared, I like talking to the pediatrician a lot. In my country, a doctor will never talk to you about reading, and reading is strange to kids. It's not something intuitive. It's good that in this country they teach kids how to read because it helps their development a lot. so it's good that doctors do this. Another shared about the gift of the book. Well, it seems good to me that they do those check-ins with my son. I appreciate that they're able to give us a book. I tell my kids that they have to take care of it, that they have to read the book because the pediatrician gave it to him. Next slide, please. And so now we'll dig more deeply into some of the work that we did around Reach Out Read implementation. And so in the introduction, Dr. Mogilner shared the Reach Out Read model, which again, its power in so many ways really rests in its simplicity. It's giving age, language, and culturally appropriate children's book, providing anticipatory guidance and modeling regarding shared reading, and then maintaining literacy-rich clinical environments. Next slide. So our team was interested, though, in what actually was happening in the exam room as part of Reach Out Read implementation. And so we started by asking what was described in the literature. And so two of our students, Nila Thurasamy and Mayuri Reddy, spent time going through the literature and did a scoping review. And what they found among 27 research articles at the time that had reported on Reach Out and Read, there was really a lot of consistency in reporting anticipatory guidance by clinicians, as well as distribution of the children's book. Where there was more variability was in the maintenance of literacy-rich waiting environments and modeling. So much so that just over half had reported anything about maintaining literacy-rich waiting rooms. And then only about a third reported clinician modeling as part of Reach Out Read implementation. Next slide. And so, that really drove us to want to understand what was happening locally in our own clinics. And so this was work that we did, qualitative work, going and engaging with local clinics that were participating in the larger study that we were conducting at the time. And so, because the work was done during the pandemic, we had wanted to go into the exam rooms, we weren't able to. And so what we did was ask clinicians to walk us through the process of implementing Reach Out and Read using a method called process mapping. And again, what we found was pretty strong consistency in terms of the delivery of the children's book as well as anticipatory guidance. But the key point of variation was in modeling. Next slide. And so this slide is very busy, but what I just want to point out with it was that what we found also was that how clinics kind of perceive the mission of Reach Out and Read really also drove how they implemented the model. And so in particular, the group that really saw Reach Out and Read as an opportunity to promote early relational health and really kind of focusing on cultivating safe, stable, nurturing relationships. That was where we saw modeling actually the most consistently implemented. Next slide. So, this was interesting to us because, like when you go back and you read the giants of the field, so Dr. Needleman, Dr. Others on how Reach Out and Read is on the Reach Out and Read model. Modeling is always kind of highlighted as really one of the essential elements in the interaction. And in fact, like when we asked clinical experts on modeling or about the Reach Out Read modeling, we heard about its importance. And so this was work that one of our fellows did, interviewing clinical experts about core components of Reach Out and Read. And so when you model in the exam room, you often find yourself saying, okay, she's sort of interested in me telling her what the pictures are. Now let's see how she reacts when you do it. Look how she turns to you. I'm okay, but you're the one that she's really paying attention to. And I think it's a good way into helping parents feel that, first of all, they have this great power and potential. And so, we appreciated this tension, right? Where, sort of there was a consensus around the importance of modeling really being kind of an essential element of reach out read implementation. And yet, like kind of reflecting on the reality of what we were seeing, we also saw less consistent. In fact, that was the component where we saw the least consistency in its implementation. And so we want to examine, to what extent modeling really made a difference. Next slide. And so we built on, we leveraged an opportunity with existing data from an ongoing randomized clinical trial to examine to what extent the presence of modeling made a difference in the home literacy environment. And so what we found was actually strong associations between the quantity, quality, and diversity of reading experiences when modeling was present compared to when it wasn't. And in fact, taking a step further, we found the dose response pattern. So when one component, which was typically just giving a book to the family, was implemented, we saw no statistically significant difference between no components and one. However, when the children's book was paired with anticipatory guidance, we did see an effect, a statistically significant effect. And in fact, the biggest association or largest magnitude of effect we saw when three components, so book, anticipatory guidance, and modeling, were implemented. And the effect size in the range of zero 0.3 is actually consistent with effect sizes that we see in much more intensive interventions in early childhood, like home visitation. Next slide. And so, this really resonates with what we've heard from families on the importance of not just telling families what to do, but really showing them. And so, this was one parent who we were interacting with during a study around how healthcare professionals can better support early relational health. And one of the things that they shared was they tell you to do something, but saying it and showing you how to do it is a little bit different. Next slide. So in closing, I'd like to just kind of leave kind of reflecting on a couple of questions. So, reflecting on our vignette, what if Nelson's medical home had implemented high quality reach out and read? How may have things looked differently later? And perhaps most importantly, what if Nelson and his family came to your office today? Next slide. So there's so many people to acknowledge as part of this work, which are here. And thank you for the opportunity to be here today. I'm happy to take some questions.
Thank you so much, Dr. Jimenez. That was wonderful. I would love to open it up for questions. If people want to write questions in the chat, that would be amazing. And maybe while people are doing that, I can start. I can start with one. When I heard you speak about this, or months ago, and then when I read one of the articles that you wrote and we presented at our Resident Journal Club, it really made me think more deeply about how I'm training our residents and our clinicians, because I think just stressing the importance of what we can do. It's not just telling parents what you can do at home, actually modeling and showing parents how it's done. And I think one of the things that I really took away, from so much of what you've taught us, is sort of the feelings that parents might have about being inadequate or not being able to do this properly, and then seeing, you can do it and you're better at it than I am, and and I think, I know it's made a difference in how I practice, and also just strengthening that clinician bond to the parents, right? When I tell the parent, oh my God, look at how they're looking at you. They love, you're much better at this. And it really goes a long way. So my question for you is, are we going to be, and maybe you don't know the answer, but I think this really needs to be sort of fundamental part of reach out and retraining. So for future training iterations, we need to really focus in there, have videos about it, have, more sort of intentional attention paid to it. And like, what have you done in your own clinic sites, or what do you think is the best way that we can be, short of going in, and I have been going in with our residents and really modeling the modeling, but if you have any tips or suggestions on how we can do that more intentionally.
Yeah, no, it's thank you so much for the question. And it is like incredibly humbling and validating to hear to hear it. A few thoughts. I mean, I think one of the things that I've certainly noticed is that there is such a there's such a opportunity to kind of open the visit through modeling, and that in of itself is like kind of reinforcing, I think, for us. The experience of being able to kind of listen deeply to a family, to be able to kind of have shared attention on the book, to be able to engage with them in that way. It's so relational, and it's I think certainly for me, but I think I speak for many of us. Like those relationships are really kind of what provide energy throughout the day. In light of like all our other kind of demands and responsibilities, which of course are important, it is those relationships and it is that connection which keeps it going, and is probably one of the most impactful aspects of the work. And so, I mean, dating back to like the giants of the field, the founders of pediatrics, it was like when you read like Brazelton or when you read others, they honed in on like this like aspect of the patient or parent clinician relationship as being so central to the art of pediatrics. And so, I think it's sort of a long-winded way of getting at I think once we introduce this to trainees, once we show them how, I do think there is like a reinforcing feedback loop that's going to happen. The more you do it, I think the more you're going to want to do it, which is just going to kind of reinforce it.
No, I'm only smiling because I had an interaction with a resident last week where I went, after PAS, and we spoke about this more. I went in, I brought him the book. I was reading actually to this 7-month-old who was sitting in the mom's lap, and the baby's looking and drooling. And then I read this short book, and then I took it away to give to the parent, and the baby started to cry. All started laughing. And later on that day, I heard my resident telling someone else, "You had to see what Leora did. She was reading this book, and then she gave the book to the mom, and the kid started crying." So it is, I mean, to your point, it really is self-reinforcing. And I think you can get hooked on it. You start doing it and you get such positive reinforcement, it's almost like infectious. So
Yeah.
that's great. There was a comment, I'll read it in the Q&A from Joanna Tsapalis. It's more of a statement than question, telling parents that even if they can't read, they can tell a story with the pictures. The bonding is just as important. So, which is so true. Which
Yeah,
is
I mean, 1000% agree. Again, it's the people is the most important element of all of this. And so, like offering that to families, empowering families in that way, to recognize that, as parents, like they have this really incredible opportunity to deepen that relationship and so, books is one way to do that. The words are probably the least important, particularly like at like an early developmental stage, like infancy, like early toddlerhood, where like really it is about that kind of joint attention interaction. Certainly like as kids get older and they move more into kind of linguistic development, in creating those kind of language rich kind of experiences is important. But that said, the power of storytelling around like pages, you can't be discounted either.
there's another question. Any tips to engage children with autism? Because when I open books in front of them, they get annoyed. They sometimes throw away the books.
Oh gosh, that's such a great question, and certainly one that's kind of that's dear to my heart as a developmental pediatrician. And so again, I think this is where like modeling is so important and can really help to kind of set like sort of what this is going to look like. It's not going to be perfect. And so, I think sometimes like we have sort of an ideal image in our mind of what it should look like. And the reality is the reality. And so, really helping families coaching families to understand this may not look perfect. It may take, like many times. It may, like many times the child may not be in the mood, and that's okay. It's still, an opportunity to just kind of keep on coming back, looking for times of the day that like again, maybe more sort of relaxed, more sort of mellow and again like an opportunity to really help to kind of set the mood or build on an existing mood. And so this is where again, like kind of the flexibility and the art are so critical.
And I think even, I mean, to that point, it may even be pointing out to them that in an exam room, which is very stimulating, and maybe there's a lot of fear of what's going to happen, it may not be the opportune time to be reading to your child. I mean, maybe it is, maybe it's not. And then kind of discussing that and saying, look, you need to figure out exactly what you were saying. There may be times of the day that where this really works well and times or places where it doesn't, and finding those moments and finding those situations or locations where you can read with your child, and thinking about like what are their sensory needs, what works for them. That's also a teaching point, and it might be that in that moment in that crazy exam room is not the place.
Yeah,
So
absolutely. And again, I think this is like, like a real opportunity to kind of sort of take a relational lens towards, towards what we do as pediatricians and really kind of help families to, seek those opportunities that are going to, like deepen their understanding of their child, help the child sort of understand their parent better. And so, again, one size never fits all, and that's okay.
I see one more question. One of the biggest barriers to modeling is time management during the visit, especially in underserved settings with large high needs patient panels. Finding ways to optimize the limited time available with patients remains an important challenge. Any recommendations?
Yeah, so this is such a great question. And I think like one that we talk about often. And so again, like I do think like there is something to there's something to, like what we were just saying about sort of parent-child interactions as well as clinician um, um, parent interactions. We really need to kind of read the room and understand kind of what,
Mhm.
what are kind of the central tasks of this visit and like what are like kind of the most pressing needs. In that context, I think we can often find that, like being able to engage in the reach on read model and implementing it with using modeling in many ways can sometimes even create efficiencies in the way the visit unfolds, right? It offers opportunities for developmental surveillance or monitoring. It offers opportunity to be able to rapport build with the family. So, like I think like when we can get creative and we can think about, like, okay, like how can we sort of use this time I think we can often find that, like, so for example, it's sort of a different topic, but sort of related. Like I often hear this as well, like as when primary care practices are beginning to implement developmental screening, and there's a concern that it's going to add time to the workflow. And yeah, like like when practices end up like sort of finding the workflow that works right for their clinic, what they often like the feedback I often hear is like, wow, this has actually improved our flow. And so I think there's something similar here as well.
Yeah, I agree. I think I got that pushback when we started Reach Out and Read years ago. It's going to add time to the visit. And I think if you can be strategic, read the room, um, incorporate the book into the visit, it often saves time. And I think it also helps build that trust that we were talking about between the clinician and the parent. I know, especially when I'm running late and I can go in and give a book right at the beginning, and especially when there's a really lovely interaction between the parent and the child, and I can comment on it and give them encouragement, I feel like that in the long run is time efficient. So there's one additional question. What are the next areas of study you think could and should be explored regarding early literacy and early relational health?
Oh gosh, thanks so much for the question. Yeah, so a few thoughts. I can share a little bit about like what our team has been thinking about, but then certainly what others are doing as well. And so, we've been thinking a lot about reach out read implementation and like what are kind of like essential elements that need to happen like in every visit versus like what components might lend themselves more to kind of the adaptable periphery, right? Like so like being able to kind of tailor to the encounter, to the visit, to the clinic site. And so I think like really reflecting on, like how do we sort of ensure that we implement reach out read in a way that's going to really deliver the impact, right? And not dilute its effects, but then also not be too prescriptive where like, we're putting too much on the visit and then, inadvertently discouraging implementation, particularly for sites that are expanding or sort of new to the model. I think one of the things that's going to be discussed later today, which is an area that certainly our team has been really interested in, is how do we create integration with our efforts in literacy promotion within the visit, within primary care, and work with our colleagues in other sectors to really align and create synergy across what we do. And so, like our team just finished up a study examining reach on read implementation and integrating it with efforts through the Help Me Grow program here in New Jersey. And so, I think, again, um, leaving sort of the idea that, like we see, like one group of kids in pediatric primary care, which are different than kids in preschool that are different from kids in home visitation. It's all the same kids. And we all have the same opportunity to be able to, or have an opportunity to be able to support them. And so thinking about how we kind of break down traditional silos to help reinforce what we do in the office through literacy promotion, but then also to reinforce what other folks are doing in other sectors when we have families in our visits, I think is another area that is a key opportunity.
Yeah, I think that's such an amazing point. Looking at sort of cross sector across all the different organizations that are working with that same patient population. In New York City, we have City's First Readers, which Jesse Lizio presented some of the research a few weeks ago, looking at libraries, looking at other community sites, literacy organizations, together with Reach Out and Read, to see how can we sort of like the sum being, what is it? The sum is more than all of its parts, than the whole of its parts, because I think we're giving the same messages and thinking sort of very purposefully about how we enforce that, not how we emphasize it and how we can all work together, I think is such an incredible point. And then I guess we'll take one last question. Any specific recommendations for residency programs? I know that's pretty general, but I think for faculty members, for clinicians who are teaching residents, any specific recommendations?
Yeah, so it's another terrific question. And maybe this isn't as specific as it should be, but in so many ways, like Reach Out and Read is like a movement, right? And so we've spent a lot of time thinking about how reach out and read just doesn't affect the child, right? It also affects the parent who's delivering, who's in the process of shared reading with their kid, right? Something about that experience is affecting the dyad. It's not limited to one person. I think that also extends to the way we can think about reach out and read implementation as clinicians, right? So like it's not just that, implementing reach out and read is having an impact on the parent and the child, it's also affecting us. And it's changing us. And, like it's shaping our lens on the parent-child relationship and, like what health is, what wellness is, what is really important and matters. And so I think with our trainees in particular, we have this really incredible opportunity to kind of shape kind of their worldview and their lens of how they practice pediatrics. And I think Reach Out and Read is truly kind of at the forefront of that, and being able to kind of help to bring to, bring to attention, um, like the call to action that the early relational health policy statement made of like being on the threshold of a paradigm shift in pediatrics. Again, I think every time that we teach Reach Out and Read, every time that we support our trainees in implementing the model, I truly do think we're taking one step forward to like that vision.
And I'm so glad you brought that up, because there has been research looking at the impact of practicing in a site with Reach Out and Read, and what that, how that, obviously the families, but the impact on us as clinicians, and sort of how people feel when they're able to bond with families over books and give out books to their patients. Anecdotally, I can say when we get new books at our site, the joy on people's faces and just how excited it makes them. So I think, it's nice that there's evidence to support that, but I think we all experience that ourselves, how the impact that having Reach Out and Read in a site, what it does to us. And I think kind of getting back to the residency question, I think there are so many things in residency that are not joyful, and that can be onerous and annoying. So I always like to savor those positive moments and really, capture that joy, and really engage. I'm sort of answering the question too, but really try to engage the residents in the practice of Reach Out and Read. I know you said it's a movement, and it truly is, but really trying to get our residents involved, take an active role. For us, it's helping, having them pick books, talk about, where are gaps, what do we need, what's missing in what we're offering, are there better ways of, implementing our program. And I think really engaging the residents and making them active participants in the program, I think, is a really great way to have people have more of a sense of ownership and responsibility in the program. And I'll just take a shameless plug here. Some of you may be aware of the Reach Out and Read sort of national resident champion program, where there was an application process a while ago. There were I forget, maybe 6 programs last year. There are a number more coming on this year, where residents are champions at their sites, and they get national mentorship and get to work with national leaders in implementing Reach Out and Read at their programs, and also working on materials that can be used to enhance the practice of Reach Out and Read. So I would say, for all people involved in residencies, think about that when the next call for more resident champion comes out in about a year. And I know, hopefully I won't get in trouble for saying this, but we're hoping to implement something, at Reach Out and Read of Greater New York, where even if it's not sort of the national resident champion, we have more of a local Reach Out and Read champions in New York, New Jersey too, sort of in the local area, where residents who are interested can take more of an active leadership role, working with faculty, and also working with each other. I think building that, which is why I said I love how you said it's a movement, building that community of practitioners who are practicing Reach Out and Read, and really trying to connect with each other and with families, and develop the best way for promoting the program. I think it's a great opportunity. So stay tuned. Hopefully I didn't jump the gun, but those of you in New York, New Jersey, stay tuned for more information about that. And then the call for the next resident champion national iteration will be probably in March, I would think. So you have a ways for that. And then I see another comment that was posted. Implementing Reach Out and Read isn't just benefiting patients and parents, it's changing us and our understanding of what health and well-being is, which I think is very beautiful. And then someone said, reading is a vital sign in pediatrics, which I love that. I love that a lot. So I think these are all things that, probably each one of us resonates with all of us. And I don't see any other questions. But I just wanted to say thank you so much Manny, this was a wonderful talk. And I know, again, every time I hear you speak or read your work, it makes me realize what, sort of is a challenge to all of us to step up and think about ways we can deepen the impact that Reach Out and Read is having. And as I'm thinking about it, it's obviously having on our patients and on their relationships with their parents, but also on us as clinicians, and how we practice and bring more joy into our lives. So I really, really appreciate that. I'm going to turn it back over to our Reach Out and Read team. And thank you again.
Thank you, Leora, and thank you everyone so much for this opportunity.